Hi, I'm John Hunter. I'm a psychiatrist at Mount Sinai Hospital in Toronto.
I'm Bob Maunder, and I'm also a psychiatrist at Mount Sinai Hospital in Toronto.
In healthcare, almost everything we do depends on the alliance we build with our patients. All of the credibility and trust that we rely on to assess, reassure, and treat our patients depends on this relationship. When we avoid an important topic, we miss an opportunity to strengthen that alliance.
Today's topic is a risk factor for illness we don't often consider: childhood adversity. When we assess a patient for the first time, we usually ask about risk factors for health like smoking, allergies, and a family history of common diseases. However, a history of adversity in childhood is just as important a risk factor, yet most doctors don't even ask about it. We refer to adverse childhood experiences as ACEs, and asking about them could improve your relationship with your patients. Simply providing a safe environment to talk about ACEs, listening to what patients say, and believing them is often beneficial. And it doesn't have to lead to referrals to specialists. Just having the conversation is often enough.
You probably already know that severe childhood adversity, like sexual or physical abuse, increases the risk of mental illness and addiction. However, most doctors don't know the whole story. Here's what you may be missing. First, there are many other kinds of adverse childhood experiences. ACEs include witnessing violence at home, having a parent with a mental illness or an addiction, or losing a parent through separation or death. And the list goes on. Second, the more ACEs a person has experienced, the higher their risk of chronic physical illnesses, including cardiovascular, respiratory, and liver diseases, as well as cancer. In fact, ACEs can contribute to a lot of the illnesses that you manage with your patients.
So why don't doctors ask? Well, the doctors we speak to are understandably concerned about some important barriers. And the first barrier is time. Obviously, a negative screen doesn't take very long, but even a positive screen for ACEs typically adds less than 5 minutes. As a one-time investment in improving your understanding of a patient and your alliance with them, 5 minutes is time well spent. For comparison, it's about the same amount of time you would spend clarifying someone's alcohol use, say using the CAGE questionnaire. The second barrier is a lack of mental health resources. Fortunately, asking about ACEs doesn't usually lead to a new need for mental health support. Many people are content to have told you something relevant and to have been heard. The conversation doesn't usually open a can of worms. And if your patient does need more support, avoiding the subject probably wasn't helping anyway. The third barrier is that we don't want to needlessly upset our patients. But asking about ACEs with respect and consent is usually not upsetting. Providing a safe environment, giving a little context, and asking permission to continue goes a long way towards making patients comfortable and allowing them to move on if they would rather.
Talking about ACEs should feel safe and comfortable, at least as comfortable as any of the other extremely personal health-related questions that we ask people. So we're going to describe one method of asking about ACEs respectfully and efficiently, which we call the CARE method. An important principle to start with is that choosing the right words is not essential. Patients tell us that what is essential is being asked in a way that feels safe and to be believed. If you keep those things in mind, even asking awkwardly is better than not asking at all. The name of the CARE method can help you remember its 4 easy steps. We'll go through each step now and provide a link at the end of the video to remind you of these steps later.
It starts with getting consent. That's C. A simple consent question would be, some childhood and young adult experiences that are pretty common but difficult can affect your health later in life. I'd like to ask you about things that may have happened when you were younger. Is that okay? Or, if you're already talking about a clinical condition that suggests a higher likelihood of ACEs, like chronic pain, addiction, or depression, you could use that for context. Let's say you're talking with someone about recurrent headaches. You could say, since we're talking about chronic pain, I'd like to ask you about some childhood and young adult experiences that are common in this situation. Is that okay?
If the patient indicates that it's okay to go on, then the next step is A, for asking. When asking about ACEs, you don't have to be precise. It may be better to give a little list that conveys the general idea. The list sort of gives your patient permission to describe other similar things. You might say, When you were young, did you have experiences that were frightening or that made you feel unsafe? For example, were you hit or touched in a way that you didn't want or bullied? Did you feel unprotected or unloved? The most important part of asking is actually listening to how your patient responds. If they start telling you something in the middle of your question, stop and listen. If they tell you they don't want to talk about it, acknowledge that and move on. Listening well and following your patient's cues are the most important parts.
So that's C, consent, and A, asking. If your patient doesn't want to talk about it or doesn't have anything to report, then you're done, and it's probably taken less than a minute. If they have something to tell you, move on to R for reflecting and E for engaging. To reflect on what has been said, you validate what your patient has told you and indicate that you're willing to think and talk about it together. You can say, "Thank you for sharing that." Sometimes experiences like that have an impact on how you respond to stress later in life. I wonder if you draw any connection between those events and your current situation. Again, it's vital to listen to how your patient responds.
The final step is to engage. In this step, you defer to your patient about what comes next. You can say, "Are you comfortable sharing more with me?" Or, "Is this something you would like to talk about more at another time?" Listen to what your patient says and follow their lead. Many people are content to have shared something relevant and don't need to talk more. And that's it. You're done.
Remember the CARE model. Get consent, ask your questions and listen to the response, reflect on what you have heard, and engage in the next steps. So let's add childhood adversity to the risk factors that you already ask about routinely. Just like smoking, ACEs increase the risk of many health problems, so they are very relevant.
And as with allergies, if you don't know about ACEs, you can inadvertently harm some patients who are sensitive to medical procedures. You might think of ACEs as similar to a family history of disease. You can't change them, but knowing about ACEs may improve your care. If you want to read more about the CARE method and the evidence behind this presentation, follow this link. Thanks for listening.